So how do you counsel a patient with newly diagnosed BPDCN? What do you prepare for them, for their future treatments?
I do, of course, have a discussion with them about the fact that it is a rare disease, and I think that's always something that we need to talk with the patient. And I personally think that the patient should be treated at a center which has some experience of using these treatment options, and the fact that the centers have experience of using these agents. So that's I think a very important point, especially when we are assessing newly diagnosed patients. I think the fact that it is an aggressive malignancy and there is lack of second line or third line options, I think that's something that I talked with the patients earlier on, and about whether or not I would refer them for a clinical trial at that point. So those are the things that I would bring up talking with the patients. I think as we will talk about that, it is different times that we are dealing with right now. There is the COVID-19 and complications related to the fact that we are worried about these patients that can develop COVID-19, and if they are, usually we are worried about patients with heme malignancies and developing infections.
Yeah, I still, however, counsel patients that they need to show up. It's hard to do telemedicine with a rare disease. I think you do need to look at the skin. You can't do that through telemedicine very well. They're going to be coming in for outpatient therapy. It's an intravenous drug after all, so it has to be given in an infusion center. I have no experience with its administration in the home. I don't even know if it can be dispensed that way. Again, you need to check blood counts and you need to check albumin. And so there's just really no way around this. COVID yes or COVID no, they're going to have to come into the clinic and see a person anyhow. And so because they keep getting cycles and there is no end to it as long as patients respond, at least at the time of administration, they can have a medical evaluation. They may not need to have an in-person evaluation mid-cycle. You could always get counts through home care or through a local laboratory that might be less busy than coming into a busy oncology clinic. But on the first day of cycle, then that's the time when I see these patients.
I think the fact that it is the first cycle is inpatient, I think certainly it helps, in sense of COVID-19 because you're admitting the patients. I think the outpatient administration is going to be challenging, and I believe, you bring a very important point that once the patients are in remission and they are getting tagraxofusp as sort of like maintenance type of schedule, I do get frequently asked questions about the fact that whether they could stop it for a time period, but as you can imagine, this being a aggressive malignancy and the fact that we don't have good second line or third line options, I would usually tell the patient that I would not to stop the therapy, especially given the fact if they are working. I mean, there's no reason then in that kind of circumstances stop therapy and let the disease progress, and then you have a different problem in your hand.
Yep, I would agree. And so they continue to use drug until progression, at which time you either look for an alternative investigational agent or you can go to some acute leukemia-based regimen, such as an ALL-based regimen. Any other points to share?
I think there are, of course, newer agents that are being evaluated in the clinical trial. They all looking at the fact that the CD123 is highly expressed on this tumor, and there is at least two promising drugs that are in clinical trial. One is the antibody drug conjugate IMGN 632, which is using alkylating agent as a payload, which could be used, of course, to target this disease. And again, it's enrolling patients right now. There is a by targeting CD123 as well. And again, those are still promising. And unlike our initial intuition that patients who progress through tagraxofusp actually do not lose the expression of CD123, and again, which allows us to target CD123 by these two options. I certainly think that is unique about this disease mechanism of resistance to tagraxofusp, in contrast to B-cell malignancies, where when we use CD19 and CD22 therapies, that the expression of CD19 or 22 was altered. But again, I think that allows us to enroll these patients for those clinical trials, and still remain cautiously optimistic about the outcome of those trials.
Great. Well, I appreciate your insights and both of our experiences with tagraxofusp and with BPDCN.
Well, thank you. I thoroughly appreciate your insight as well.
Thanks.